The Fenamate group includes potent NSAIDs used for acute and chronic arthritic conditions. Like most NSAIDs, gastric irritation is a common side effect of Fenamates, and patients with a history of peptic ulcer should avoid taking this group of drugs. Other side effects include edema, dizziness, tinnitus, and pruritus. Two Fenamates are meclofenamate sodium monohydrate and mefenamic acid. Piroxicam and Oxicam is indicated for long-term arthritic conditions such as rheumatoid arthritis and osteoarthritis. It too can cause gastric problems such as ulceration and epigastric distress, but the incidence is lower than for some other NSAIDs. It is well tolerated, and its major advantage over other NSAIDs is its long half-life, which allows it to be taken only once daily. Full clinical response to piroxicam may take 1 to 2 weeks. This drug is also highly protein-bound and may interact with another highly protein-bound drug if taken together. Piroxicam should not be taken with aspirin or other NSAIDs. Cyclooxygenase 2 inhibitors became available in the last several years to decrease inflammation and pain. Selective cyclooxygenase 2 inhibitors are drugs of choice for patients with severe arthritic conditions who need high doses of an anti-inflammatory drug because large doses of NSAIDs may cause peptic ulcer and gastric bleeding. Currently, there is one drug, Selective or Celebrex, classified as cyclooxygenase 2 inhibitor. Nabumetone is a similar drug that can be used, however, it is not considered a true cyclooxygenase 2 inhibitor. Nabumetone inhibits cyclooxygenase 2 more than cyclooxygenase 1. Do not confuse Celebrex which is a cyclooxygenase 2 inhibitor, with Celexa, which is a selective serotonin reuptake inhibitor for depression, or Cerebrex, which is a hydantoin anticonvulsant. Adults frequently use NSAIDs to treat pain associated with inflammation caused by osteoarthritis, rheumatoid arthritis, and neuromuscular skeletal disorders. As older adults age, the number of drugs taken daily increases. Therefore, drug interactions are more common, especially when numerous drugs are taken with NSAIDs. With the use of NSAIDs, the GI distress, including ulceration, is 4 times more common in older adults. Hospitalization is often necessary. Corticosteroids control inflammation by suppressing or preventing many of the components of the inflammatory process at the injured site. Corticosteroids have been widely prescribed for arthritic conditions, and although they are not the drug of choice for arthritis because of their numerous side effects, they are frequently used to control arthritic flare-ups. The half-life of a corticosteroid is long, usually greater than 24 hours, and it is administered once a day in a large prescribed dose. When discontinuing steroid therapy, the dosage should be tapered over a period of 5 to 10 days. Immunosuppressives are used to treat refractory rheumatoid arthritis, or arthritis that does not respond to anti-inflammatory drugs. In low doses, selected immunosuppressive agents have been effective in the treatment of rheumatoid arthritis. Drugs such as azathioprine, cyclophosphamide, and methotrexate, primarily used to suppress cancer growth and proliferation, might be used to suppress the inflammatory process of rheumatoid arthritis when other treatments fail. In one study of the patients receiving cyclophosphamide, few new erosions of joint cartilage were present, suggesting that the disease process was not active. Immunomodulators treat moderate to severe rheumatoid arthritis by disrupting the inflammatory process and delaying disease progression. Interleukin receptor antagonists and tumor necrosis factor, or TNF blockers, are two groups of drugs classified as immunomodulators. And interleukin receptor antagonist blocks activity of interleukin by inhibiting it from the binding to interleukin receptors located in the cartilage and bone. Interleukin is a pro-inflammatory cytokine that contributes to the synovial inflammation and joint destruction. TNF blockers bind to TNF and block it from attaching to TNF receptors on synovial cell surfaces. By neutralizing TNF, a contributor to synovitis, inflammatory disease process is delayed. So aspirin is an analgesic drug which is administered to reduce pain and inflammatory symptoms, to decrease body temperature, and to inhibit platelet aggregation. Its interaction to other drugs may increase risk of bleeding with anticoagulants and other NSAIDs, increase risk of hypoglycemia with oral hypoglycemic drugs, and increase ulcerogenic effects with glucocorticoids. Pharmacokinetics includes, if taken orally, it is 80 to 100%. Protein binding is 80 to 90% and crosses placenta. Its half-life is 2 to 3 hours for low dose and 15 to 20 hours for high dose. It is excreted 50% in the urine. Its side effects include anorexia, nausea, vomiting, diarrhea, dizziness, confusion, hearing loss, heartburn, rash, abdominal pain, and drowsiness. Its adverse reactions include tinnitus, urticaria, ulcerations, GI bleeding, and it could be life-threatening that may lead to agranulocytosis, hemolytic anemia, bronchospasm, anaphylaxis, thrombocytopenia, Ray's syndrome, hepatotoxicity, and leukopenia. This drug is contraindicated to people with hypersensitivity to salicylates or NSAIDs, people with flu or virus symptoms in children, anticoagulant therapy, GI bleeding, bone marrow suppression, third trimester of pregnancy, especially to patients with renal or hepatic disorders, gout, and alcoholism. Now here are the nursing responsibilities when administering aspirin. First, determine a medical history. Ask patient if there is any history of gastric upset, gastric bleeding, or liver disease. Aspirin can cause gastric irritation. It prolongs bleeding time by inhibiting platelet aggregation. Obtain a drug's history. Report if a drug-drug interaction is probable. The nursing diagnosis may be risk for injury related to vertigo or chronic pain related to tissue swelling of rheumatoid arthritis. Planning. The patient's pain will be reduced within 12 to 24 hours. The patient's inflammation will also be reduced within 1 week. For the nursing interventions, monitor serum salicylate level when patient takes high doses of aspirin for chronic conditions such as arthritis. Normal therapeutic range is 15 to 30 milligrams per deciliter. Mild toxicity occurs at serum level of greater than 30 milligrams per deciliter, and severe toxicity occurs at greater than 50 milligrams per deciliter. Observe patients for signs of bleeding such as dark stools, bleeding gums, petechiae, ecchymosis, and purpura when patient takes high doses of aspirin. Advise patient not to take aspirin with alcohol or with drugs that are highly protein-bound, such as the anticoagulant warfarin. Suggest that patient inform the dentist before a dental visit if taking high doses of aspirin. Instruct patient to discontinue aspirin 3 to 7 days before surgery to reduce risk of bleeding. Keep aspirin a bottle out of reach of children, and educate parents to call Poison Control Center immediately if a child has taken a large or unknown amount of aspirin. Warn patient not to administer aspirin for virus or flu symptoms in children. Ray's syndrome, manifested by vomiting, lethargy, delirium, and coma, has been linked with aspirin and viral infections. Acetaminophen is usually prescribed for cold and flu symptoms. Inform patient that aspirin tablets can cause GI distress. Inform patient with dysmenorrhea to take acetaminophen instead of aspirin 2 days before and during the first 2 days of the menstrual period. Direct patients to report side effects, and instruct patient to take aspirin with food at mealtime or with plenty of fluids. Enteric-coated aspirin helps prevent GI disturbance. For the evaluate the effectiveness of aspirin in relieving pain. If pain persists, another analgesic such as ibuprofen may be prescribed. Determine whether patient has any side effects to aspirin. One of the first NSAIDs introduced was indomethacin. It is used for rheumatoid arthritis, gouty arthritis, and osteoarthritis, and is a potent prostaglandin inhibitor. It is highly protein-bound and displaces other protein-bound drugs, resulting in potential toxicity. It has a moderate half-life of 4.5 hours. Indomethacin is very irritating to the stomach and should be taken with food. Two other para-chlorobenzoic acid derivatives, Silandac and tolomentine, produce less severe adverse reactions than indomethacin. Tolmethine is not as highly protein-bound as indomethacin and solindac, and it has a short half-life. This group of NSAIDs may cause sodium and water retention and increase blood pressure. Diclofenac sodium, a phenylacetic acid derivative, has a plasma half-life of 1.2 to 2 hours. Its analgesic and anti-inflammatory effects are similar to those of aspirin, but it has no or minimal antipyretic effects. It is indicated for rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. Diclofenac is available in per-orum, extended-release, and topical 1% gel preparations. Adverse reactions are similar to those of other NSAIDs. Ketorolac, another phenylacetic acid derivative, is the first injectable NSAID. Like other NSAIDs, it inhibits prostaglandin synthesis, but it has greater analgesic properties than other anti-inflammatory agents. Ketorolac is recommended for short-term management of pain. For post-surgical pain, it has shown analgesic efficacy equal or superior to that of opioid analgesics. It is administered intramuscularly in doses of 30 to 60 milligrams every 6 hours for adults. Ketorolac is also available in per-orum or tablets or capsules, IV, and intranasal preparations. The propionic acid group is a relatively new group of NSAIDs. These drugs are aspirin-like but have stronger effects and create less GI irritation. Drugs in this group are highly protein-bound, so drug interactions might occur, especially when given with another highly protein-bound drug. Propionic acid derivatives are better tolerated than other NSAIDs. Gastric upset occurs, but it is not as severe as with aspirin and indomethacin. Severe adverse reactions such as blood dyscrasias are not frequently seen. Ibuprofen is the most widely used propionic acid NSAID, and it may be purchased over the counter in lower doses. 6 other propionic acid agents are phenobarbital, calcium, naproxen, ketoprofen, florbiprofen, and oxaprozin. Ibuprofen belongs to the nonsteroidal anti-inflammatory drug propionic acid derivative. It is indicated to reduce inflammatory process, to relieve pain, anti-inflammatory effect for arthritic conditions, and to reduce fever. Its interactions to other drugs increase bleeding time with oral anticoagulants, increase effects of phenytoin, sulfonamides, and warfarin, decrease effect with aspirin, and may increase severe side effects of lithium. Ibuprofens are well absorbed from the GI tract. These drugs have a short half-life but are highly protein-bound. If ibuprofen is taken with another highly protein-bound drug, severe side effects may occur. The drug is metabolized in the liver to inactivate metabolites and is excreted as inactive metabolites in the urine. They have a short onset of action, peak concentration time, and duration of action. It may take several days for the anti-inflammatory effect to be evident. Side effects include anorexia, nausea, vomiting, diarrhea, edema, rash, purpura, tinnitus, fatigue, dizziness, lightheadedness, anxiety, confusion, and fluid retention with edema. Adverse reactions include GI bleeding and can be life-threatening that may lead to blood dyscrasias, cardiac dysrhythmias, nephrotoxicity, and anaphylaxis. It is contraindicated to patients with severe renal or hepatic disease, patients with asthma, peptic ulcer, anticoagulant therapy, and especially to patients with bleeding disorders who are pregnant, who are lactating, and has systemic lupus erythematosus.
Good day everyone, this is Group 5 and in this video, we are going to discuss the agents for pain and inflammation, anti-inflammatory, opioid, and non-opioid analgesics.
Inflammation is a reaction to tissue injury caused by the release of chemical mediators that trigger both a vascular response and the migration of fluid and leukocytes or white blood cells to the injured site. The process of inflammation is a protective mechanism in which the body attempts to neutralize and destroy harmful agents at the injury and to establish conditions for tissue repair. Note that not all inflammation is caused by infection. Other causes of inflammation include trauma, surgical interventions, extreme heat or cold, and caustic chemical agents. The two phases of inflammation are the vascular phase, which occurs 10 to 15 minutes after an injury, and the delayed phase. The vascular phase is associated with vasodilation and increased capillary permeability, during which blood substances and fluid leave the plasma and go to the injured site. The delayed phase occurs when leukocytes infiltrate the inflamed tissue. Various chemical mediators are released during the inflammation process. Histamine is the first mediator in the inflammatory process, causes dilation of the arterioles and increased capillary permeability, allowing fluid to leave the capillaries and flow into the injured area. Kinins such as the bradykinin also increase capillary permeability and the sensation of pain. Prostaglandins that have been isolated from the exudate of the inflammatory sites are among them. Prostaglandins have many effects that include vasodilation, relaxation of the muscle, increased capillary permeability, and sensitization of nerve cells to pain. Cyclooxygenase is the enzyme responsible for converting arachidonic acid into prostaglandins and their products. This synthesis of prostaglandins causes inflammation and pain at a tissue injury site. There are two enzyme forms of cyclooxygenase. Cyclooxygenase 1 protects the stomach lining and reduces blood platelets, and cyclooxygenase 2 triggers inflammation and pain. There are 5 characteristics of inflammation, also called as the cardinal signs of inflammation: redness, swelling or edema, heat, pain, and loss of function. Redness occurs in the first phase of inflammation. Blood accumulates in the area of tissue injury because of the release of the body's chemical mediators. Histamine dilates the arterioles. Swelling is the second phase of inflammation. Plasma leaks into the interstitial tissue and at the injury site. Kinins dilate the arterioles, increasing capillary permeability. Heat at the inflammatory site can be caused by increased blood accumulation and may result from pyrogens, or substances that produce fever that interfere with the temperature regulating center in the hypothalamus. Pain is caused by tissue swelling and the release of chemical mediators. And lastly, function is lost because of the accumulation of fluid at the tissue injury site and because of pain, which decreases mobility at the affected area. Whenever there is a tissue injury, this will cause a momentary vasoconstriction and a release of chemical mediators. The chemical mediator histamine causes the dilation of the arterioles, which causes redness or the blood congestion. There will be also fever, which is caused by the heat, which is caused by the blood accumulation. There will be also an increase in the capillary permeability, which is caused by the chemical mediator kinin, thus induces swelling, and there will be pain. Pain and swelling then will cause a loss of function in the injury site. Drugs such as aspirin inhibit the biosynthesis of prostaglandin and are therefore called prostaglandin inhibitors. Because prostaglandin inhibitors affect the inflammatory process, they are more commonly called anti-inflammatory agents. Anti-inflammatory agents also relieve pain, reduce elevated body temperature, and inhibit platelet aggregation. Nonsteroidal anti-inflammatory drugs are aspirin and aspirin-like drugs that inhibit the enzyme cyclooxygenase, which is needed for the biosynthesis of prostaglandins. These drugs may be called prostaglandin inhibitors with varying degrees of analgesic and antipyretic effects, but they are used primarily as anti-inflammatory agents to relieve inflammation and pain. Their antipyretic effect is less than their anti-inflammatory effect. With several exceptions, NSAID preparations are not suggested for use in alleviating mild headaches and mild elevated temperature. Preferred drugs for headaches and fever are aspirin, acetaminophen, and ibuprofen, given to children and adults with high fever. NSAIDs are more appropriate for reducing swelling, pain, and stiffness in joints. There are 7 groups of NSAIDs: salicylates, Para-Chlorobenzoic Acid derivatives or indoles, Phenylacetic acids, Propionic acid derivatives, Fenamates, Oxicams, and Selective cyclooxygenase 2 inhibitors. The first 6 NSAID groups on the list are known as first-generation NSAIDs, and the cyclooxygenase 2 inhibitors are called second-generation NSAIDs. The drug aspirin comes from the family of salicylates derived from salicylic acid. Aspirin is also called acetylsalicylic acid after the acetyl group used in the composition of aspirin. Aspirin is a prostaglandin inhibitor that decreases the inflammatory process. It is also considered an antiplatelet drug for patients with cardiac or cerebrovascular disorders because aspirin decreases platelet aggregation and thus blood clotting is decreased. Because high doses of aspirin are usually needed to relieve inflammation, gastric distress is a common problem. In such cases, enteric-coated tablets may be used. Aspirin should not be taken with other NSAIDs because it decreases the blood level and effectiveness of NSAIDs. Aspirin and other NSAIDs relieve pain by inhibiting the enzyme cyclooxygenase, which is needed for the biosynthesis of prostaglandins. Like I've mentioned before, there are two enzyme forms of cyclooxygenase. Cyclooxygenase 1 protects the stomach lining and regulates blood platelets, promoting blood clotting. Cyclooxygenase 2 triggers pain and inflammation at the injured site. Usually, NSAIDs inhibit or block both COX-1 and COX-2. Inhibition of COX-1 produces the desirable effect of decreasing platelet aggregation, but the undesirable effect of decreasing protection to the stomach lining. Stomach bleeding and ulcers may occur with aspirin and NSAID agents. When COX-2 is inhibited, pain and fever are reduced and inflammation is suppressed, but COX-2 inhibitors do not cause gastric ulcerations and have no effect on platelet function. New NSAIDs called COX-2 inhibitors block only COX-2 and not COX-1. These drugs leave protection for the stomach lining intact, meaning no gastric bleeding and ulcers, but still deliver relief for pain and inflammation. Patients may be hypersensitive to aspirin. Tinnitus, ringing in the ears, vertigo or dizziness, and bronchospasm, especially in asthmatic patients, are symptoms of aspirin overdose or hypersensitivity to aspirin. Patients should not take diflunisal if they are hypersensitive to aspirin. Diflunisal is a derivative of salicylic acid, although it is not converted to salicylic acid in the body. Infliximab belongs to the immunomodulator, tumor necrosis factor blocker. It is to treat moderate to severe rheumatoid arthritis and Crohn's disease. Two other drugs is it may decrease effectiveness of vaccines. Concurrent immunosuppressives may increase risk for infection or adverse effects, and these drugs have a half-life of 8 to 9.5 days. They have an unknown onset of action, peak concentration time, and duration of action. Side effects include headache, dizziness, coughing, fatigue, chills, hot flashes, anxiety, insomnia, depression, nausea, vomiting, diarrhea, constipation, flatulence, weight loss, rash, alopecia, dry skin, and urinary frequency. Contraindicated to patients with hypersensitivity, who have heart failure, and especially to have those who have renal or hepatic dysfunction, bone marrow suppression, those who have diabetes mellitus, those who have immunosuppression, multiple sclerosis, seizures, and those who are older adults. Now, here are the nursing responsibilities when administering infliximab. First, determine a medical history. Ask patient if there is any history of seizures, diabetes mellitus, multiple sclerosis, or kidney or liver disease. Then obtain baseline renal and liver function tests. The nursing diagnosis may be impaired physical mobility related to severe pain or chronic pain related to tissue swelling from rheumatoid arthritis. The patient's pain will be reduced within 12 to 24 hours, and the patient's inflammation will be reduced within 1 week. For the nursing interventions, first obtain negative tuberculosis skin test prior to initiating infliximab therapy, and then monitor patient for signs and symptoms of infection. If a serious infection occurs while receiving infliximab therapy, the antibiotic therapy should be initiated and infliximab discontinued. Monitor laboratory tests for blood dyscrasias. You can conduct CBC and renal and liver function tests. Discontinue IV dose of infliximab if the patient develops acute infusion reaction. It may be manifested by chest pain, fever, chills, dyspnea, pruritus, urticaria, hypotension, or hypertension. Monitor patient up to 2 hours of post-infusion for acute infusion reaction. For patient teaching, encourage patient to keep medical appointments and have regular scheduled laboratory tests for renal, liver, and complete blood count functions for early detection of blood and renal and liver damage. Then advise the patient to avoid live vaccine while taking Infliximab. Teach patient to report dizziness, chills, depression, dyspnea, severe infections, seizures, fatigue, or rash immediately. Teach the patient to report severe infections immediately also. For the evaluation, evaluate patient's response to the DMARD if pain persists. Drug regimen may need modification. Determine the presence of adverse reactions. Drug therapy for pain may need to be changed. Malarial drugs may be used to treat rheumatoid arthritis when other methods of treatment fail. The mechanism of action of antimalarials in suppressing rheumatoid arthritis is unclear. The effect may take 4 to 12 weeks to become apparent, and antimalarials are usually used in combination with NSAIDs in patients whose arthritis is not under control. Examples of antimalarials include quinine, quinidine, chloroquine, amodiaquine, and mefloquine.
Gout. So what is gout? So gout is a painful inflammatory illness that primarily affects men. So the symptoms are caused by the accumulation of uric acid crystals in the joints. Now, a recurrent inflammatory illness, it is also marked by a recurrent inflammatory illness marked by hyperuricemia or high uric acid levels in the blood, and periods of acute joint pain, most commonly in the big toe. Now, here are some of the anti-gout drugs. Pathophysiology of gout. So hyperuricemia, defined as blood uric acid levels above 7 mg per deciliter in men and 6 mg per deciliter in women, can occur through two mechanisms. One is the increased uric acid production and impaired renal uric acid excretion. Acute attacks are caused by sodium urate crystallization, which are the sodium salt in the uric acid, in the synovial space. The formation of urate crystals causes irritation, causing a complex chain of events. Tophi. So tophi, or big and gritty deposits, can accumulate in the afflicted joint if hyperuricemia is continuous. In addition, urate crystal formation in the kidney may induce renal injury. Fortunately, if gout is discovered and treated early, the disease can be stopped, and these long-term consequences can be avoided. Overview of the drug therapy. So, in patients with gout, drugs are used in two ways. First, they are given short-term to relieve symptoms of an acute gouty attack. Second, they are given long-term to lower blood levels of uric acid. Now, in patients with infrequent flare-ups or fewer than 3 per year, treatment of symptoms may be all that is needed. So, nonsteroidal anti-inflammatory drugs, or NSAIDs, are considered first-line agents for relieving pain of an acute gouty attack. Glucocorticoids are an acceptable option too. Now, in the past, colchicine was considered a drug of choice for acute gout, even though it has poor risk or benefit ratio. Today, colchicine is generally reserved for patients who are unresponsive to or intolerant of safer agents. Patients suffering from chronic gout, tophaceous gout, or recurrent gout, more than 3 or more gouty attacks per year, hyperuricemia medications are prescribed. These are the 3 categories of medication that can be used. One is those that reduce uric acid production, those that promote uric acid excretion or uricosuric drugs, and those that convert uric acid to allotoin. Anti-inflammatory gout, or first is the colchicine. Colchicine, or the Colchis, Mitigare is an anti-inflammatory medication having gout-specific effects. Colchicine was once thought to be the first line of treatment for gout. However, due to the prevalence of GI toxicity and the availability of safe and effective alternatives, its use has been decreased. Now, the therapeutic use. 2 applications in gout. First, it can be used short-term to treat an acute gouty attack. Second, it can be used to long-term to prevent attacks from recurring, and Colchicine is approved for both uses. So Mitigare is approved only for prophylaxis. Acute gouty arthritis. High-dose colchicine can produce dramatic relief of an acute gouty attack. Within hours, patients whose pain have made movement impossible are able to walk. Inflammation disappears completely within 2 to 3 days. For the prophylaxis of gouty attack, low dose of colchicine when given during asymptomatic periods can reduce the frequency and severity of acute flare-ups. Colchicine is also used as prophylactic when urate-lowering medication is started because gouty episodes tend to rise at this time. So what are its mechanism of action? So allopurinol and its major metabolite alloxanthine inhibits xanthine oxidase. So it is an enzyme required for the uric acid formation. XO, or the xanthine oxidase, catalyzes the final 2 reactions that lead to the formation of uric acid from breakdown products of DNA. Pharmacokinetics. So for the absorption, allopurinol is well absorbed 80% following oral administration. It is widely distributed in tissue and breast milk. It has a protein binding of 1%. For the metabolism and excretion, it is metabolized to oxypurinol, an active compound with a long half-life. 12% excreted unchanged. 76% excreted as oxypurinol. It has a half-life of 1 to 3 hours. Oxypurinol has 18 to 30 hours. Now for the pharmacodynamics, its onset for the per Oraman IV is 30 to 60 minutes. Now for the peak is 24 hours and it has a long duration of action. For the drug interactions, now, statins, as noted, like atorvastatin and simvastatin and other statins, can increase the risk of colchicine-induced muscle injury. Now, the P-glycoprotein or the PGP inhibitors and inhibitors of CYP3A4, those are the drug interactions. Now, for the contraindications, colchicine should be used with care in adult and debilitated patients and in patients with cardiac, renal, hepatic, and GI disease. Now, for both acute therapy and long-term prophylaxis, dosage should be adjusted on the basis of liver function, kidney function, and the usage of interacting drugs. Uric acid inhibitor. One of the example is allopurinol. So, allopurinol is not an inflammatory drug. Instead, it inhibits the final steps of uric acid biosynthesis and therefore lowers the serum uric acid levels, preventing the precipitation of an attack. Now, it is the current drug of choice for chronic tophaceous gout. Now, reversing hyperuricemia lowers the risk of nephropathy caused by the urate crystal deposition in the kidney. Now, allopurinol can be used to treat hyperuricemia caused by cancer chemotherapy as well as certain blood dyscrasias such as polycythemia vera, myeloid metaplasia, and leukopenia. Hyperuricemia develops during chemotherapy because when cells die, the breakdown of DNA releases uric acid to minimize hyperuricemia. Allopurinol should be administered before chemotherapy starts. So what are its mechanism of action? So, allopurinol and its major metabolite alloxanthine inhibits xanthine oxidase. So, it is an enzyme required for the uric acid formation. XO, or the xanthine oxidase, catalyzes the final two reactions that lead to the formation of uric acid from breakdown products of DNA. Pharmacokinetics. So, for the absorption, allopurinol is well absorbed 80% following oral administration. It is widely distributed in tissue and breast milk. It has a protein binding of 1%. For the metabolism and excretion, it is metabolized to oxypurinol, an active compound with a long half-life. 12% excreted unchanged. 76% excreted as oxypurinol. It has a half-life of 1 to 3 hours. Oxypurinol has 18 to 30 hours. Now for the pharmacodynamics, its onset for the per oram and IV is 30 to 60 minutes. Now for the peak is 24 hours, and it has a long duration of action. What are its adverse effects? Allopurinol is generally well tolerated. Most serious toxicity is a rare but potentially fatal hypersensitivity syndrome. It is characterized by rash, fever, eosinophilia, and dysfunction of the liver and kidneys. Initial therapy may elicit an acute gouty attack. This can be prevented by giving colchicine or low-dose NSAIDs. So mild side effects include GI reactions like nausea, vomiting, diarrhea, abdominal discomfort, and neurologic effects of drowsiness, headache, and also the metallic taste. Prolonged use, more than 3 years, may cause cataracts. Periodic ophthalmic examinations are recommended, so if there is a long-term use. Now for the drug interactions, so allopurinol can inhibit hepatic drug metabolizing enzymes, thereby delaying the inactivation of other drugs. This interaction is of particular concern for patients taking warfarin, whose dosage should be reduced if possible. Combined use with mercaptopurine or azathioprine should be avoided because both of these anti-cancer drugs are substrates for XO, hence could accumulate to toxic levels in the presence of allopurinol. Uricosurics. So uricosurics accelerates uric acid excretion by blocking reabsorption. So this medication are useful for treating chronic gout, but they should not be used during acute gouts. Propionic, or a uricosuric, has been on the market since 1945. So propionic can be taken with colchicine to begin initial therapy for relieving symptoms of gout and inhibiting uric acid reabsorption. Small doses of colchicine should be given before adding propionic. Now, if gastric irritation occurs, propionic should be taken with meals. It has an average half-life of 1.7 to 31.2 hours and is 34 to 44% protein bound. Now, for the side effects may include flushed skin, sore gums, and headache. Kidney stones resulting from the uric acid could be prevented by releasing water intake and maintaining a urine pH above 6. Now, blood dyscrasias occur rarely, so aspirin should be avoided because it causes uric acid retention. Now, for the nursing process, let's start with the assessment. So we need to obtain a medical history of any gastric, renal, cardiac, or liver disorders. Anti-gout drugs are excreted via kidneys, so sufficient renal function is really needed. Drug dosage and drug selection might need to be changed. Next, we need also to obtain a drug history. We need to report on possible drug-to-drug interactions. We need to assess the serum uric acid value for future comparisons. And also we need to record the urine output and use initial urine output for future comparisons, and we need to check the laboratory tests such as BUN, serum creatinine, ALP, AST, ALT, and lactase dehydrogenase or LDH, and compare with future laboratory test results. Now for the diagnosis, there are two. We have the tissue integrity and the impaired related to inflammation of the great toe. Pain, acute pain related to tissue swelling also. For the planning, patients' pain from gout will be absent or controlled without side effects. Now for the nursing interventions, we need to report the GI symptoms, gastric pain, nausea, vomiting, or diarrhea for patients taking anti-gout drugs. We need to administer these drugs with food to alleviate gastric distress. Now we need to record urine output because the drugs and uric acid are excreted to the urine. Kidney stones might occur. So both water intake and urine output should be increased. We also need to monitor laboratory tests for renal and liver function like the BUN, serum creatinine, ALP, AST, and ALT. Now for the patient teaching, the general patient teaching is that we need to encourage patients to keep medical appointments and to have regularly scheduled laboratory tests for renal and liver function and CBC. Now, some anti-gout drugs may cause blood dyscrasias, so blood tests should be monitored. So we need to also instruct patients to increase fluid intake, for it will increase drug and uric acid excretion. Now, what are the side effects? We need to advise patients to report to a healthcare provider of any side effects of the anti-gout drugs, such as anorexia, nausea, vomiting, diarrhea, stomatitis, dizziness, rash, pruritus, and metallic taste. Now, we need to also advise patients to have a yearly eye examination because visual change can result from prolonged use of allopurinol. Now, for the diet, we need to warn patients to avoid alcohol and caffeine because they can increase uric acid levels. We also need to suggest that patients to take large dose of vitamin C while taking allopurinol. Kidney stones may occur. We also need to tell patients not to ingest foods high in purine content such as organ meats, salmon, sardines, gravy, and legumes. Foods with purine increase uric acid levels. Now, direct patients to report any gastric distress. Encourage them to take anti-gout drugs with food or at mealtime. Now, what are the cultural considerations? We need to provide additional explanation as needed related to the disease process and the purpose of the drug and its side effects. We also need to identify conflicts in values and beliefs. Suggest follow-up by a community health nurse to determine patient compliance with drug regimen and the effectiveness of the prescribed drug therapy. Evaluation. We need to evaluate response to the anti-gout drug. Now, if pain persists, the drug regimen may need modification from the doctor. Now, we need to determine the presence of the adverse reactions. Drug therapy for gout pain may need to be changed. Pain, gaya ng sabi na nasa polydent na advertised, you have to endure the pain. Also, sabi ni Danielle, stop acting like you know my pain. Stop acting like you know it. I don't know how to act. Now, let's talk about pain. Pain is an unpleasant sensory and emotional experience related to tissue injury. So, it is also called the fifth vital sign. Now, you know what pain threshold is? So, pain threshold reflects the level of stimulus needed to create a painful sensation, and individual genetic makeup contributes to the variations in the pain threshold from person to person. So, the amount of pain a person can endure without having it interfere with normal function is called pain tolerance. Yun yung pain tolerance natin. So, Yung ating pain tolerance na influensya ng maraming factors, kagaya natin age, gender, culture, ethnicity, previous experience, anxiety level, and the specific circumstances such as traumatic events. Now, meron tayong analgesics. So, both non-opioid and opioid are prescribed for the relief of pain. The choice of analgesic depends upon the severity of the pain. So, mild to moderate pain is frequently relieved with the use of non-opioid, also known as non-narcotic, then analgesics. Moderate to severe pain usually requires an opioid or narcotic, and also analgesics. Now, neuropathic pain is an unusual sensory disturbance that often involves neural supersensitivity. Now, this pain is due to the injury or disease of the peripheral nervous system, or PNS, or the central nervous system, which is the CNS. What is the pathophysiology of pain? Now, this is according to the gate theory by Melzack and Wall in 1965. Now, tissue injury activates nociceptors, and it causes the release of the chemical mediators such as substance P. Prostaglandins, bradykinins, histamine, serotonin, acetylcholine, glutamate, adenosine triphosphate or ATP, the leukotrienes, and the potassium. Now, itong mga substance, mag-initiate sila ng action potential along a sensory nerve fiber and sensitize pain receptors. Nociceptive potential are transmitted by the afferent nerve fibers. So, yun yung pathophysiology natin ng pain. Now, a pain signal originates in the periphery and progresses throughout the central nervous system. Now, understanding how and where pharmacologic drugs work is critical for pain management. So, endorphins are neurohormones na na-produce ng ating body that naturally decrease pain conduction, na decrease niyang pain, although mechanism is not fully understood. So, paano ba natin malalaman yung severity ng pain? Sometimes, we ask patients na i-rate ang kanilang degree sa pain from 0 to 10, 10 being the most severe pain. Now, a pain signal originates in the periphery and progresses throughout the central nervous system. Now, understanding how and where pharmacologic drugs work is critical for pain management. So, endorphins are neurohormones na na-produce ng ating body that naturally decrease pain conduction, na decrease niyang pain, although mechanism is not fully understood. So, paano ba natin malalaman yung severity ng pain? Sometimes, we ask patients na i-rate ang kanilang degree sa pain from 0 to 10, 10 being the most severe pain. Now, merong under-treatment ng pain. So, what is under-treatment of pain? So, it is a major health issue in the healthcare, sa healthcare natin today. So, meron mga factors. Some causes of under-treatment includes social cultural factors that influence a patient's willingness to admit na being in pain, as well as financial constraints, yung walang pera, nahihirapan na magpa-hospital. Also, the inability of the patient to describe pain, fear of addiction on the part of the patient, inability of the nurse to measure pain, also the lack of regular pain assessment rounds. Attitudes of the healthcare team, also part of that is unwillingness to believe the patient's report of pain, the inaccurate knowledge on the part of the healthcare provider concerning addiction and tolerance. Also, and prescription of an inadequate analgesic dose. Now, as a result, yung undertreatment, so as a result of unrelieved pain, the patient may develop increased respiratory and heart rates, hypertension, increased stress response, urinary retention, fluid overload, electrolyte imbalance, glucose intolerance, hyperglycemia, pneumonia, atelectasis, anorexia, paralytic in-use, constipation, weakness, confusion, and infection. Meron tayong two types of pain. We have the acute one and the chronic one. So, acute one, pain occurs suddenly, is of short duration, less than 3 months, and responds to treatment. It can result from trauma, tissue injury, inflammation, or surgery. Now, for the mild pain, non-opioid drugs such as acetaminophen and NSAIDs are used. For moderate pain, combination of non-opioid and opioid drugs such as oxycodone and acetaminophen, and for the severe pain, potent opioids such as morphine or hydrocodone. And so natapos tayo sa acute pain, let's go ahead to the chronic pain. So pain persists for more than 3 months and is difficult to treat or control non-opioid drugs. Non-opioid drugs are suggested. So opioids, if used, should meet these criteria. So we have the oral or transdermal, long duration of action, and it should include adjunct therapy. And also, it shall cause minimal respiratory depression. Now let's go ahead to non-opioid analgesics. So, non-opioid analgesics such as aspirin, acetaminophen, ibuprofen, and naproxen are less potent than opioid analgesics and are used to treat mild to moderate pain. Non-opioids are usually purchased over-the-counter, but cyclooxygenase 2 or COX2 inhibitors require a prescription from the doctor. Now, non-opioids are effective for the dull, throbbing pain of headaches, dysmenorrhea, or somewhat called menstrual pain, inflammation, minor abrasions, muscular aches and pain, and mild to moderate arthritis. So most analgesics also have antipyretic effect and will lower an elevated body temperature. Also, some such as aspirin have anti-inflammatory and antiplatelet effects as well. Now, here are some of the examples of the non-opioid analgesics. Now let's go into the nonsteroidal anti-inflammatory drugs. So all NSAIDs have an analgesic effect as well as an antipyretic and anti-inflammatory action. So over-the-counter drugs such as aspirin, ibuprofen, and naproxen. So aspirin, salicylate NSAID is the oldest non-opioid analgesic drug still in use. So several organizations have recommended aspirin products not to be given to children and adolescents younger than 19 years of age during episodes of fever or viral illnesses because of the danger of the Ray's syndrome. So Ray's syndrome is a rare but serious condition associated with viral infections treated with salicylates that cause swelling of the brain and liver. Instead, recommended acetaminophen. Now, in addition to analgesic, antipyretic, and anti-inflammatory properties, aspirin decreases platelet aggregation, or somewhat called clotting. Now, aspirin is the drug of choice for alleviating pain and inflammation in arthritic conditions. But when given in high doses, severe GI irritation and possible ulceration develop in approximately 20% of the patients. Now, here is a picture of Ray's syndrome. Now, what are the side effects and reactions? So, a common side effect of NSAIDs are gastric distress, including anorexia, nausea, vomiting, and diarrhea. So, these drugs should be taken with food at mealtime or with a full glass of fluid to help reduce this problem. So, excessive bleeding might occur as a side effect if an NSAID is taken for dysmenorrhea during the first 2 days of menstruation. Now, the adverse effects of salicylate toxicity includes tinnitus, vertigo, hyperventilation, and potential metabolic acidosis. Now, some patients are hypersensitive to aspirin. Dyspnea, bronchospasm, and urticaria are some of the symptoms that indicate anaphylaxis to salicylate products. Certain foods also contain salicylate, such as prunes, raisins, paprika, and licorice. So those with a hypersensitivity to aspirin and salicylate products may be sensitive to other NSAIDs. So this hypersensitivity may be related to inhibition of the COX enzyme by the salicylate. Opioid analgesics. So it is prescribed for moderate and severe pain. Addiction is defined as a psychological and physical dependence upon a substance beyond normal voluntary control, usually after prolonged use of a substance, so addiction. So morphine. So morphine is a prototype opioid and it is obtained from the sap of seed pods of the opium poppy plant. So codeine is another drug obtained from opium. So in the past decades, many synthetic and semi-synthetic opioids have been developed, for example, meperidine. Now, opioids not only suppress pain, but pain impulses, but also suppress respiration and coughing by acting on the respiratory and cough centers in the medulla of the brainstem. Now, most opioids, with the exception of meperidine, have an antitussive, so cough suppression effect. Now, in addition to pain relief and antitussive effects, many opioids possess antidiarrheal effects. So, common side effects with high doses of most opioids include nausea and vomiting, particularly in ambulatory patients. Now, constipation. So a moderate decrease in blood pressure and the orthostatic hypotension. Now, high doses of opioids may also cause respiratory depression, urinary retention, usually in older adults. Also, antitussive effects. Morphine. Now, morphine is the prototype of the strong opioid analgesics and remains the standard by which newer opioids are measured. So, morphine has multiple pharmacologic effects, including analgesia, sedation, euphoria, respiratory depression, cough suppression, and suppression of the bowel motility. What are its therapeutic use? So, now the principal indication of morphine is relief for moderate to severe pain. Morphine may also be administered preoperatively for sedation and reduction of anxiety. Now, morphine relieves pain without affecting other senses, for including sight, touch, hearing, and without causing loss of consciousness. Now, the drug is more effective against dull, constant pain than against sharp, intermittent. Now, for the pharmacokinetics, orally, although GI absorption can be somewhat erratic. Now, for the IV, for quick relief of severe pain, such as with AMI, or for fast relief of anxiety and to reduce hypertension. Morphine is 30% to 35% protein bound and may be also administered rectally and epidurally. Oral morphine undergoes first pass-hepatic metabolism, meaning the liver metabolizes the drug before morphine is available to the rest of the body. Now, only a small amount of morphine crosses the blood-brain barrier, or the BBB, to produce an analgesic effect. Now, for the half-life of 1.5 to 2 hours and 90% is excreted through urine. Remember that morphine crosses the placenta and is excreted in the breast milk of the mother. Now, for the pharmacodynamic, its onset is rapid when administered IV. So for subcutaneous and IM injection is slow. Now, for the duration of action with most types of drug administration is 3 to 5 hours. With controlled release morphine sulfate tablets, duration is 8 to 12 hours. What are the adverse reactions of morphine? You have the respiratory depression. It is the most serious adverse effect. Death following overdose is almost always from respiratory arrest. Constipation. Opioid promotes constipation through action in the central nervous system and gastrointestinal tract. Now, let's go ahead to the nursing process. First, we go up to the assessment. We need to obtain a medical history. Contraindications for morphine include severe respiratory disorders, increased intracranial pressure, and severe renal disease. Now, morphine may cause seizures. We also need to determine a drug history and check for drug allergies. Report if a drug-to-drug interaction is probable. Morphine increases the effects of alcohol, sedatives, and hypnotics, antipsychotics, psychotic drugs, and muscle relaxants, and it can cause respiratory depression. We also need to assess the vital signs, noting the rate and depth of respiration as well as pupil size for future comparisons. Opioids commonly decrease respirations and systolic blood pressure and may cause meiosis. Monitor urinary output. Morphine can cause urinary retention. Also, we need to assess the type of pain, location, duration before giving opioids. Now, let's go ahead for the nursing diagnosis. It has pain, acute pain related to surgical tissue injury, breathing pattern ineffective related to excess morphine dosage. Now, risk of fall and also risk for constipation related to morphine. Now, let's go to the planning. The patients will pain will be reduced or alleviate. Nursing intervention. So first, we need to administer morphine before pain reaches the peak to maximize effectiveness of the drug. We need to monitor the vital signs at frequent intervals to detect respiratory changes. Fewer than 10 respirations per minute can indicate respiratory distress. We need to record the patient's urine output because urinary retention is the side effect of morphine. Urine output should be at least 600 milliliters per day. You also need to check for bowel sounds for decreased peristalsis. Constipation is a side effect also of morphine. A dietary change or mild laxative might be needed. So, kailangan natin yun. We need to check for the pupil changes and reaction. Pinpoint pupils can indicate morphine overdose. And then have naloxone as available as an antidote to reverse respiratory depression if morphine overdose occurs. We also need to validate the dose of morphine before administration. Check older adults for alertness and irritation because confusion is a side effect of morphine. So we need to raise the side rails of the bed to take other safety precaution as necessary. Patient teaching. So let's go to the general patient teaching. We need to encourage patients not to use alcohol or CNS depressants with any opioid analgesics such as morphine. Respiratory depression can result as well as dizziness and the potential fall risk. Now, we also need to suggest non-pharmacologic measures to relieve pain as the patient recuperates from surgery. So, as recovery progresses, a non-opioid analgesics may be prescribed. Now, for the side effects, alert patients that with continuous use, opioids such as morphine can become addicting. So, if addiction occurs, inform patients about methadone treatment programs and other resources in the area. That's why there is addiction to one now. So, encourage patients to report dizziness while taking morphine. Dizziness could be due to orthostatic hypotension. We need to advise patients to ambulate with caution or only with assistance. We also need to teach patients to report difficulty in breathing, blurred visions, and headaches. Now, for the cultural considerations, we just have to look at these slides and then you will see the following considerations. Evaluation. We need to evaluate the effectiveness of morphine in lessening or alleviating pain using consistent pain scale. Now, if pain persists after several days, the dose should be increased or the opioid should be changed. Now, we need to determine the stability of vital signs. Any decrease in the respiration or the blood pressure should be reported. Meperidine. So, what is meperidine? It's one of the first synthetic opioids. It is classified as a Schedule II drug. Meperidine has a shorter duration of action than morphine, and its potency varies according to the dosage. Now, meperidine can be given orally or via IM and IV routes, and is primarily effective in the GI procedures. It does not have the anti-tussive property of opioid preparations. Now, during pregnancy, meperidine is preferred to morphine because it does not diminish the uterine contraction and causes less neonatal respiratory depression. So, meperidine also causes less constipation. Meperidine is indicated for patients with chronic pain, severe liver dysfunction, sickle cell disease, a history of seizures, severe coronary artery disease or CAD, or cardiac dysrhythmia. Hydromorphone. So, hydromorphone is a semi-synthetic opioid similar to morphine. The analgesic effect is approximately 6 times more potent than that of morphine, with fewer hypnotic effects and less GI distress. Now, this opioid has a faster onset and a shorter duration of action than morphine. Now, this drug is given orally, rectally, or via subcutaneous IM and IV routes for the relief of moderate to severe pain. Now, side effects. So many side effects are known to accompany the use of opioids. Of particular importance are signs of respiratory depression, respirations of less than 10 per minute. Other side effects include orthostatic hypotension, drowsiness, dizziness, weakness, confusion, constipation, and urinary retention. So now for the contraindications, patients with head injuries, with respiratory distress, with asthma, patients in shock, or for those who have very low blood pressure. Let's move on to the opioid use in special populations. First are the children. Pain management in children is complex because it is more difficult to assess their pain. Some children will not verbalize discomfort when they are in severe pain. Now, and some are fearful of treatments like injections that relieve pain. Use of ouch scale, like ouch, and can be unhelpful in determining the child's level of pain. A child, like an adult, should be given medication before the pain becomes severe. So the use of oral liquid medication for pain relief, if appropriate, is generally more acceptable to the child. Now for the older adults who are 65 years of age or older require adjustment to drug doses to avoid severe side effects. Now in older adults, side effects from the use of opioids are more pronounced, therefore the nurse must closely monitor, I will closely monitor for adverse reactions in order for adults who take opioid analgesics. Now for the pain assessment may be more difficult with older adults due to the decrease of cognitive and sensory perceptual abilities. Dementia or hearing and visual deficits may interfere with communication, like they don't know how to react with pain. Cognitively impaired individuals. Now, any cognitively impaired individual may be unable to report pain adequately. So we use a measurement scale that is appropriate for the patient. Some physical signs include moans, grimacing, clenched teeth, noisy respiration, and restlessness. Now, for the oncology patients, cancer pain is managed according to the 3 levels of analgesia based on the WHO ladder as follows. Step 1, we have the mild pain, non-opioids with or without an adjuvant medication. Step 2, moderate pain, non-opioids and mild opioids with or without an adjuvant medication. Step 3, severe pain, stronger opioids at higher dose levels with or without an adjuvant medication. Now, for individuals with a history of substance use disorder, a thorough pain assessment is necessary to find out the cause of pain. Now, the nurse needs to know that opioids are effective and safe in this population, even though larger doses in greater frequency may be required.
So let's proceed to the adjuvant therapy. So adjuvant analgesics medication have been developed for other purposes and were later found to be effective for pain relief in neuropathy. It is used along a non-opioid and opioid analgesic. Examples are anticonvulsants, antidepressants, corticosteroids, antidysrhythmics, and local anesthetics. Anti-seizures medications such as gabapentin act on the peripheral nerves and CNS by inhibiting spontaneous neuronal firing, and it is used for neuropathic pain and for prevention of migraine headaches. And the tricyclic antidepressants such as amitriptyline prevent the reuptake of serotonin and norepinephrine in the cells. Lower dosage of TCA than those usually prescribed for depression are effective in treating peripheral neuropathy. And corticosteroids, it is effective analgesic by reducing nociceptive stimuli, and the antidysrhythmics such as mexiletine, it blocks sodium channels to reduce pain. And for the local anesthetics such as lidocaine patch, it serves as effective analgesic by reducing nociceptive stimuli. Adjuvant medications potentiate opioid analgesia for severe persistent pain in diabetic neuropathy, cancer, migraine, headaches, and rheumatoid arthritis. When any of the adjuvant medications are used in conjunction with NSAID and an opioid, dosages may be kept lower to reduce adverse effects. For treatment for opioid-addicted individuals, non-medical use of prescription of opioid drugs has reached epidemic proportion. Over 1.9 million people in the U.S. meet the criteria for OUD. The FDA has toughened the safety warnings on opioids, including adding a boxed warning about the potentially lethal risk associated with the misuse. The safety warning includes a caution regarding the use of opioids during pregnancy and the risk of neonatal opioid withdrawal syndrome, which can be life-threatening. Contingency management therapy or 12-step facilitation therapy may be useful in treating prescription opioid addiction. Treatment approaches are tailored to each patient and are often combined with medication therapy. For the drug treatment, we use naloxone. It is a drug of choice in the treatment of respiratory depression associated with opioid overdose. It's a short-acting opioid antagonist that competitively attaches to opioid receptors in the central nervous system, thereby blocking activations by opioid drugs. In emergency situation, it is administered IV. However, it may also be administered IM or subcutaneously or subcut. It begins at 0.1 to 0.2 milligrams every 2 to 3 minutes until the patient responds. Careful monitoring is required to prevent opioid withdrawal. Symptoms of withdrawal: we have nausea and vomiting, abdominal cramps, hyperthermia, hypertension, and restlessness. Next drug is the naltrexone. It is approved by the FDA to treat opioid use disorder. Dosing begins at 50 milligrams daily after the patient has been opioid-free for 7 to 10 days. It is also available in an injectable extended-release form with dosing at 380 milligrams each month. Once treated with naltrexone, patients may have reduced tolerance to opioids. If they relapse after a period of abstinence and resume opioid use at previous doses, they may experience life-threatening consequences, including respiratory arrest and circulatory collapse. Next is the methadone. It is prescribed to treat persons with OUD since 1950. When taken as prescribed and combined with counseling and behavioral therapies, the administration of this long-acting opioid drug is safe and effective. The methadone has a boxed warning concerning the risk of cardiac and respiratory-related deaths due to QT prolongation and cardiac arrhythmia. Methadone used for stabilization and maintenance of persons with OUD may only be administered by programs certified by the SAMHSA or the SAMHSA and approved by state authority. Opioid treatment programs must follow federal guidelines and standards for medically monitored withdrawal and treatment. Methadone works by changing the way a person's brain responds to pain. It is an opioid receptor agonist at the receptor and an antagonist at the N-methyl-D-aspartate receptor. Taken daily, it blocks the sense of euphoria and tranquility caused by opioid use and prevents opioid withdrawal and craving. Continuation for the methadone, initial dosing ranges from 15 milligrams to 30 milligrams, followed by 5 milligrams to 10 milligrams, adjusting the dose to suppress withdrawal and block the euphoric effects of opioid. The maximum dosage is 40 milligrams on the first day of stabilization. Maintenance therapy is based on patient assessment and ranges from 80 to 120 milligrams a day. Tapering methadone should only be done under medical supervision with a dose reduction of less than 10% every 14 days. Common methadone side effects are lightheadedness, constipation, dizziness, sedation, nausea, and vomiting. Patients should be educated to prevent the theft and misuse of methadone by friends, family, and others. Methadone was designated pregnancy category C. Whether it will harm the fetus is unknown, but it is excreted into breast milk. Therefore, a decision should be made to either discontinue breastfeeding or discontinue the drug, taking into the account the importance of the drug to the mother. Next is the buprenorphine. It is a long-acting mixed narcotic agonist-antagonist. Binds to various opioid receptors in the brain, producing partial agonism at mu receptors and antagonism at kappa receptors, resulting in decreased withdrawal symptoms and cravings. Although it does produce some euphoria, there is a ceiling effect. Increasing the dose beyond a moderate level, 8 to 16 milligrams, does not increase euphoria. Therefore, it has a low potential of misuse. To further deter people from misusing buprenorphine, naloxone is added. Because of the almost complete first-pass metabolism of naloxone, it has minimal pharmacologic activity when the drug is used appropriately as a sublingual tablet. However, if the tablet is crushed and injected, the effects of naloxone lead to opioid withdrawal. This drug may be administered in qualified outpatient settings such as office, health department, or correctional facility after providers have received training. When taken as prescribed and used in combination with counseling and behavioral therapies, it is safe and effective. Initial dosing begins when the person with OUD has been opioid-free for at least 12 hours and is beginning to experience withdrawal. Dosing starts at 2 to 8 milligrams sublingual for the first day, then it is raised to 8 to 16 milligrams sublingual for 1 to 2 days. Once the patient is stable and is not experiencing cravings or significant side effects, dosing is tailored to the individual. The maximum daily dose of buprenorphine is 44 milligrams. So side effects of buprenorphine are nausea, vomiting, constipation, muscle aches and cramps, craving, sedation, headache, depression, anxiety, and withdrawal symptoms. Buprenorphine was designated pregnancy category C. Whether it will harm the fetus is unknown, but it is excreted into breast milk. Therefore, a decision should be made to either discontinue breastfeeding or discontinue the drug, taking into the account the importance the drug to the mother. Next, opioid agonists and antagonists. Medications in which an opioid antagonist is added to an opioid agonist may be used to decrease opioid abuse. It is not given for cancer pain because of the risk of potential CNS toxicity from the high doses required, and are considered safe for use during labor, but their safety during early pregnancy has not been established. For example, the drug pentazocine can be given orally as a tablet or by injection. Classified as a Schedule IV drug, butorphanol tartrate, buprenorphine, and nalbuphine hydrochloride are examples of other opioid agonist-antagonist analgesics. For nalbuphine, its pharmacokinetics and pharmacodynamics. Pharmacokinetics can be administered orally or via IM, subcut, or IV routes. It is rapidly absorbed parenterally, has a short half-life, it is metabolized in the liver and excreted in the urine. Pharmacodynamics, effective in alleviating moderate to severe pain. Onset of action is rapid and peak time occurs within 30 minutes with IV administration. Duration of action is the same for all routes of administration, approximately 5 hours. For patient safety, do not confuse Novain, a narcotic agonist-antagonist analgesic for moderate to severe pain, with Nebsin, an aminoglycoside antibiotic, or Nuprin, an OTC, analgesic, antipyretic, and NSAID. For nursing process, patient-centered collaborative care, opioid agonist-antagonist analgesic, nalbuphine. For the assessment, obtain a drug history from the patient. Report if a drug-to-drug interaction is probable. When taken with nalbuphine, CNS depressants can cause respiratory depression. Note baseline vital signs for future comparisons, and then assess the type of pain, duration, and location before giving the drug. For nursing diagnosis, pain and acute related to trauma, knowledge deficit related to lack of familiarity with the drug, planning the intensity of the patient's pain will be lessened. And for the nursing intervention, monitor vital signs, note any changes in respirations. Check bowel sounds and the date of the last bowel movement to identify constipation. Decreased peristalsis may result in constipation. A mild laxative may be necessary. Determine urine output. Report if urine output is less than 30 ml per hour or less than 600 ml per day. Administer IV nalbuphine undiluted. Do not mix with barbiturates. Patient teaching, general, warn patients not to use alcohol or CNS depressants while taking nalbuphine. Respiratory depression can occur. Suggest non-pharmacologic methods for lessening pain such as a changing position or ambulation. Side effects, advise patients to report side effects of nalbuphine: dizziness, headaches, constipation, dysuria, rash, or blurred vision, hallucinations, tachycardia, and respiratory depressions are adverse reaction that might occur. And for the cultural considerations, accept various cultural groups' use of alternative methods for relief of pain. And for the evaluation, evaluate the effectiveness of nalbuphine in relieving pain. If ineffective, another opioid analgesic may need to be ordered. Then determine stability of vital signs. Note whether a change in respirations, pulse rate, or blood pressure occurs. Then report abnormal findings. For opioid antagonists, these are antidotes for drug toxicity of natural and synthetic opioid analgesics. It has higher affinity to the opioid receptor site than the opioid being taken. Then blocks the receptor and displaces any opioid that would normally be at the receptor, which inhibits the opioid action. For the indications, reversal of post-operative opioid depression and opioid overdose. Naloxone drugs are perfect examples of pharmacologic antagonists because they reverse the respiratory and CNS depression, sedation, and hypotension caused by opioids. When receiving opioid antagonists, the patient should be monitored continuously. The opioid action may exceed that of opioid antagonists and further analgesia may be needed. For example, fentanyl and a combination of drugs given during surgery may lead to excessive respiratory depression. Naloxone may be given as an opioid antidote. The patient should be monitored his or her respiratory and CNS status closely for indication of analgesic reversal, tachycardia, nausea, vomiting, and sweating, and the possible need for further analgesia, and be observed for bleeding because the drug may cause an elevated partial thromboplastin time. Headache, migraine, and cluster. Migraine headaches are characterized by a unilateral throbbing head pain, accompanied by nausea, vomiting, and photophobia, and these symptoms frequently persist for 2 to 24 hours and for several days in some cases. 2/3 of migraine headaches are experienced by women in their 20s and 30s. Symptoms usually decrease or are absent during pregnancy and menopause. The intensity of migraine pain can disrupt daily activities. For pathophysiology, a common theory suggests a series of neurovascular events initiates a migraine headache. Neuronal hyperexcitability occurs in the cerebral cortex, especially in the occipital cortex. Specific factors that trigger a migraine headache are foods such as cheese, chocolates, and red wine can trigger an attack. Monosodium glutamate, aspartame, fatigue, stress, too much or too little sleep, missed meals, odors, light, hormone changes, drugs, and weather. The two types of migraine are migraines associated with an aura, which occur minutes to 1 hour before onset, and migraines without aura. Cluster headaches, characterized by a severe and lateral non-throbbing pain usually located around the eye, occur in a series of cluster attacks in which one or more attacks occur every day for several weeks. not associated with an aura and do not cause nausea and vomiting, and men are more commonly affected by cluster headaches than women are. Treatment for migraine headaches. Preventative treatment for migraine includes beta-adrenergic blockers such as propranolol and atenolol, anticonvulsants such as valproic acid and gabapentin, and TCA such as amitriptyline and imipramine. Treatment of a migraine attack depends on the intensity of pain. Drugs used to treat migraines include analgesics, opioid analgesics, ergot alkaloids, and selective serotonin or 5-HT receptors agonist, also known as triptans. For mild migraine attacks, aspirin, acetaminophen, or NSAIDs such as ibuprofen or naproxen may be prescribed. Aspirin may be used in combination with caffeine, meperidine, and butorphanol. Nasal spray are opioid analgesics that are occasionally used. Anti-migraine medication should be taken early during a migraine attack. Nausea and vomiting might occur, and antiemetics decrease these symptoms, and dihydroergotamine, an ergot alkaloid, can be administered subcutaneously, intramuscularly, intravenously, and may be means of a nasal spray. And the triptans, the 5-H receptor agonists, are the most recently developed group of drugs for the treatment of migraine headaches. And lastly, the somatriptan, a selective serotonin receptor agonist with a short duration of action, was the first triptan drug. It is considered more effective than the ergot alkaloids in the treating acute migraine attacks. For patient safety, do not confuse sumatriptan with zolmitriptan. Both drugs are triptans but have different dosages. They emerge a triptan used for migraines, with Amaryl, a sulfonylurea used for diabetes mellitus, or Altase, an angiotensin-converting enzyme inhibitor used for hypertension and heart failure.